I would like to welcome you to this page, and this page is dedicated to trigger point surgery. I want to spend a couple of minutes just explaining what we do, how we do it, because a lot of doctors who treat pain are not familiar with what this whole thing is, and we'll get a little bit of pushback from providers unless we kind of explain what is done. So let me step back and kind of go over the trigger points in general. We have a muscle, and the muscle contracts back and forth, right? And you have multiple muscles sitting next to each other. So those muscles move next to each other, moving arms, shoulders, head, at all at the same time. And in order for the muscles not to stick to each other, and in order for the muscles to glide, we have this smooth covering of the muscle called the muscle fascia. And the muscle fascia is usually pretty thin. It allows an independent gliding without having a lot of friction. With some form of injury, which could be very minor, something that you wouldn't have noticed routinely, you pulled a hand or you twisted uncomfortably somehow, you have a little tear. And you maybe have a tear inside of the muscle, or you have a tear of the muscle and the fascia, or just the fascia. Doesn't really matter. But at the end of the day, you have a little trauma. And as a body trying to heal it, it doesn't heal it the right way. So what happens is that the body forms a scar tissue, or increased amount of scar tissue, either between the muscle fibers or around the muscle fascia. Okay. Now remember, the muscle fascia is really nice and smooth, and as the muscle contracts and stretches out, the fascia, because it's so thin, it's able to follow. There's no really friction between the muscle fascia and the muscle fibers themselves. They kind of move all together in unison. But as the injury occurs, the muscle fascia starts to thicken up. It becomes thicker and thicker and thicker, and then you have this kind of poorly mobile or movable patch on top of the muscle or extending into the muscle. And it's usually a scar tissue. People call it as a knot, scar tissue, whatever it might be. But at the end of the day, it's most likely final mechanism is the formation of the scar tissue blob, so to speak, on the surface of the muscle, inside of the muscle, with involvement of the muscle fascia. Now, what happens next is, as the muscle continues to contract and perform its function, now the fascia has a thickened area that doesn't move as well. All right. And now you have internal friction between the muscle fascia and the muscle fibers that doesn't move. So the muscle constantly involved in that cycle of continuous injury. As a result, you have inflammation and you have pain. And the problem with this process, there is really no final solution. The options that you have are all directed toward reduction of inflammation, if you think about it. One is non-steroidal anti-inflammatories that reduce inflammation, okay? Then you have injections. Toradol, which is also anti-inflammatory, similar to Tylenol or Motrin, but just injected. Or you can have steroids that also reduce inflammation. But remember, the trauma continues with every single movement. So the process of improvement is very temporary. Usually injections involve two medications, Toradol or steroid, with local numbing medicine. And the local numbing medicine allows us to do two things: immediate reduction of the pain and the control. Meaning that if you injected in the correct area and the pain went away, then you delivered the actually acting medication appropriately. All right. So that's the two main categories. And usually this numbing with these medications and reduction of inflammation works for a couple of weeks, maybe a month or two, but then the pain comes back. I have patients that had 40, 50, 60 easily injections over the period of several years in the same area, trying to get rid of the knot of pain. But remember, it doesn't really address the problem. It just kind of tries to soften up the scar tissue. All right. Then there are techniques that's called dry needling. And the idea is you reduce inflammation, loosen up the scar tissue. So what you do, you get those little needles and you poke the holes in the scar tissue, hoping it becomes kind of smoother. All right. That's, in my mind, works temporarily also because you have to poke the holes. Maybe you have to do the steroids to reduce swelling and reduce inflammation and hope it gets better. Again, and then there's a radio frequency procedures. So basically you find the location of the scar tissue and you put a radio frequency device and you burn it. Okay, so what do you burn? What you burn is you burn a little nerve fibers that are entrapped in the scar tissue. All right. So once you burn those fibers, the nerves do not transmit the pain signal anymore. You did reduce the inflammation. You didn't solve the original problem. What you did is you killed the nerve that provides that sensation. Here's the problem. The body is designed to regenerate. All right. So usually the body can skip a gap or regenerate about 1 centimeter of tissue, or through about 1 centimeter of the tissue. And when you do the burning with radiofrequency devices, this is about the size of the burn that you get. So you get slightly longer effect with radio frequency, maybe several months, maybe 6 months, maybe a year. But eventually the nerve will find its way through to the other end. And now it transmits the same type of pain symptom from continuous inflammation that you still had for the whole year. All right. And then there's a technique of implanting the electrodes. So here's the way it works. It really doesn't reduce the inflammation, doesn't really kill the nerve. Here's the idea. They put two electrodes with a TENS unit or stimulation unit onto the nerve. And once you start providing a lot of stimuli to the nerve, what happens is the nerve gets overwhelmed by the amount of information it has to pass through. As a result, the nerve has to dump some of the information it passes, and usually the first signals that it dumps is the pain. So what happens is that you do like vibration. The vibration creates a lot of information that needs to be passed centrally. As a result, you have the appearance that the pain is gone. But reality is the pain signal just got blocked, so to speak, but the inflammation is still there. Remember, the pinching of the nerve is still there, the rubbing is still there, so it'll continue to get inflamed. And that's why I'm not a big fan of those 10 units, unfortunately. Here's what I feel is more of an anatomic approach, all right? If you have an area where your nerve is usually pinched, it's not any area, it's usually junction of the muscles, and usually there'll be a nerve attached or located right next to it or at the junction in between. And that's what happens usually on the neck, when you have one muscle going this way, one muscle going that way, and the nerve is sitting right here in the middle. And as the inflammation happens in between all those nerves, the scar tissue forms and it traps the nerve. And that's, the nerve hurts. So what we do is, first we need to localize the injury. So what we do is we have to inject local numbing medicine into the specific trigger point and make sure that your pain is improved or relieved. That means we're in a right geographic area. Your point of pain should be consistently in the same place. It cannot be going here and there. That's a completely different condition. It means that your compression is not on one level, but at multiple levels, and this surgery is not going to work. So we have to have a pain in a specific condition for a long time and not responsive to medications or other treatments. I don't want it to be your first line of treatment, because if you have a minor early inflammation, it can be treated with injection of steroids or injection of lidocaine or other less invasive techniques. So we usually ask you to go through the process of standard pain management for at least 3 to 6 months to make sure that all the more conservative methods have been exhausted before you go for surgical treatment. All right. Now, once those treatments demonstrated they're not working, we locate that area. We know that this area has an inflammation, and usually geographically or anatomically, I know where the local nerves are. And it's usually going to be location around the transition of the nerve from underneath one muscle into some form of tunnel underneath the muscle, somewhere around the scapula or around any other anatomic structure. Okay, inject the local medicine, and if the pain went away, we know that the needle is located inside of this general area where the scar tissue is. Then make a small incision, I would say about this big, about 1 inch, sometimes a little bit longer, sometimes a little bit shorter. And we carefully go down to the level of the muscle fascia and see what's going on there. Usually I see like a roundish patch of the thickened tissue located on top of several muscles or one muscle. And you usually see a nerve nearby. And there could be small nerves or big nerves. There could be nerves that are anatomically important, and then the nerves that are anatomically not very important. So if there is a anatomically important nerve, we follow the nerve from top to bottom, and under the microscopes, relieve the nerve from the surrounding scar tissue. So we kind of clear out all the scar tissues that have been created there over the years. And then remove all the scar tissue from surrounding muscles in the area. And you can actually run your finger on top of the fascia, and then boom, you see the bump. And then you keep going, bump, 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 and then boom, you get the normal fascia. So it's usually a disc or some irregular area. Sometimes I can remove it in the bigger pieces, but usually the scar tissue is removed kind of piece by piece using either scissors or electrocautery or a radiofrequency unit or whatever it might be. And then you can clearly see muscle fibers that are nice and healthy. You see the nerve that's nice and healthy, and so forth. Now, in some cases where the area of scar tissue has been there for years and people have been doing a lot of injections, you can have the area of the nerve that once you relieve it, it kind of becomes fairly prolonged, and we start worrying about the blood supply to the nerve. And in that case, what we do is we bury the nerve inside of the muscle. So what happens is that we make a little tunnel inside of the muscle, the nerve goes there, and then it's kind of covered if necessary. And the concern is, what if the new scar tissue forms And can you do anything to prevent the new scar choking up the nerve again? Yes, we can. And that's where the nerve conduits come in play. So there's a special nerve conduits. They're basically almost like a clamp made from biologic tissue, and we clamp it around the nerve and then put it outside of the muscle. And then even if the scar tissue forms, that nerve conduit protects the nerve from or decreases the chance of the nerve being pinched up again. So those are techniques of trigger point excision surgery. Sometimes we use some of the products to reconstruct the muscle fascia. Sometimes we don't. Sometimes we have to treat multiple areas at the same time. So for the nerves that are anatomically important, we try to preserve the nerves. And then there are nerves that can barely see, and they really don't produce any significant function except for being trapped inside of the scar tissue. In that case, that patch with the entrapped nerve, we just remove altogether. And the key is the distance that we have to remove should exceed the body's ability to return back to the normal function. So it's usually about 2.5 centimeters or more. I'm not the first one who invented this procedure. This procedure was originally performed by Dr. Ornstein, who is a former professor of plastic surgery in Texas. In my personal conversations with him, he did close to 2,500 to 3,000 cases with a success rate of over 95% over the 5 years. And we're seeing kind of the same degree of success as long as the procedure is appropriately performed. So this is nothing new. I'd love to tell you that I invented the procedure, but I can't because I was not the first one to do it. Dr. Ornstein is in his 80s right now. He's since retired many years ago, but I had a pleasure of communicating with him, and he's been very gracious in his explanation because they kind of allowed me to modify my technique. So the key here is if you have a consistent trigger point that is about 6 months old or longer, that is not really responding in a consistent fashion to traditional means of injections, steroids, dry needling, or radiofrequency, and you want to consider other options, give us a call, make an appointment. We'll see if you're a good candidate. Please make sure that you have kind of all your past medical history kind of organized in a way that we can track it. Usually there's a lot of things involved there. If your trigger point is migrating from one place to another, it's on the shoulder one day, on the outside of the other, on the back, whatever, then you're probably not the right candidate. You may have multiple trigger points located, and as long as they're consistent, then they can be treated. We would not treat them all at the same time. We want to make sure we do 1 or 2 at a time to make sure that our technique is successful. We also try to get it authorized through the insurances if we can. We're unable to do it through Medicare or Medicaid because there's no proper pre-authorization process there. But usually we work with private insurance companies, with workers' comp and personal injury companies. So these are the typical patients that we see. There are quite a few publications on this, not in the United States, usually in Europe. Why there is not too much research. Actually, I discussed this topic with Dr. Ornstein, and he said that really there is nothing that you can patent. There's no unique drug or equipment or something you can patent. So there's no money to be made by the vendor companies or manufacturing companies. And it's a kind of very detailed, but really not that complicated of a surgery. And that's why he feels that there is not too much research in it, and why people did not popularize it very well. Again, thank you for listening to this. If you have any questions, make an appointment. We're happy to see you.